You see in this video?
Yes, in this video I can see a child in sleeping in lying position. He's sleeping. He has I can appreciate some dysmorphic face with a small mandible, and there is deviation of right ala of the nose, and there is snoring sign is present. And after he's sleeping at the slowing, and after suddenly he woke up.
So what is your diagnosis?
It's maybe a case of obstructive sleep apnea. Obstructive sleep apnea.
Yes. And what are the differential diagnoses?
Uh, the causes of it is the causes of sleep apnea or differential diagnosis.
Differential diagnosis, tell me.
It's maybe due to adenotonsillar hypertrophy, obesity. I have to measure the do the anthropometry. It may be any neuromuscular presence of the craniofacial abnormality may be responsible for it, or any brainstem tumor may cause this type of obstructive sleep apnea.
Yeah, it is an obstructive sleep apnea. It's very easy. Sleeping patient, and also there is snoring sound. So obstructive sleep apnea, the differential diagnosis are it can be adenotonsillitis, allergic rhinitis, sinusitis, obesity complications, central hypoventilation, brainstem tumor, and syndromic. Normally, obstructive sleep apnea come with Down syndrome sometimes. So Down syndrome features we know that, and Prader-Willi syndrome, Pierre-Robin syndrome, mucopolysaccharidosis, achondroplasia. It's come as Down syndrome. So what history we ask in obstructive sleep apnea patient?
Yes, onset, course, and duration, increasing factor, aggravating factor, relieving factor, number of attack, and the sleep pattern. Is there associated with any nocturnal aneurysm present or not? Any behavioral abnormality, school problem, weight gaining, any developmental issue, any history of recurrent ear problem?
Yes. The onset course in duration, what increase and what decrease, how many times occurring at night, cessation of breathing, position during sleep, non-refreshing sleep, nightmares, nocturnal enuresis, lack of concentration in the morning, daytime somnolency, school performance, history of abnormal behavior, teeth grinding and crowding, fever, recurrent infection in the throat and ears. These are. So what are the examination we do?
Overnight polysomnography, it is the golden standard test. Here we measure, and also the
Examination. Examination.
oh, okay. Examination. Examination is ear, nose, throat examination, and is any dysmorphic feature is present or not. Anthropometry of this child, respiratory system examination, and cardiovascular system examination for palpable P2, as it can cause core pulmonary, and neurological examination.
So we do the airway, breathing, circulation, vitals, oxygen saturation. In respiratory case, oxygen saturation we tell, weight and height and plot on the centiles, ENT and dental examinations, general examinations, and general examination for any dysmorphic features present or not, cardiac and chest examinations. So what investigation we do? Investigation.
Investigations is overnight polysomnography.
Hmm.
Here we can measure the heart rate, respiratory rate, and SpO2, and we measure the hypoapnic and apnic episode.
Yes, the overnight oxygen saturation and polysomnography you do, chest X-ray you can do, lateral X-ray of the neck for adenoid, echo for pulmonary hypertension and right ventricular hypertrophy, myofunction exercise B by ENT. Management, what management we give?
Yes, I will take the focus history examination, and then management. If there is intermittent snoring and no history of apnea or no underlying medical conditions, so conservative management. But if there is any issue regarding apnea or poor weight gain or behavioral abnormality, so medical management is CPAP, nasal steroid plus minus Montelukast we can use, and surgical treatment of the underlying cause, removal of the tonsil and adenoid,
Hmm.
tracheostomy in the severe cases may be needed, BiPAP when CPAP is not tolerated.
I will involve the consultant, my pediatrician, ENT consultant, cardiologist if needed, dietitian if needed, and intranasal steroid and adenotonsillectomy. Like intranasal steroid is the treatment and surgical is adenotonsillectomy. Okay, so why Prader-Willi syndrome had obstructive sleep apnea?
Prader-Willi syndrome because there is the tongue is fall down back. For this reason, when they are in the supine position, the tongue is fall back and it causes the obstruction.
And Down
And
syndrome,
also
why
there
occur obstructive sleep apnea?
because of hypotonia. And
Not
there, yes,
only hypotonia, and also they have short neck, large tongue,
yes,
hypotonia, large adenoid, recurrent upper airway infection due to low immunity. There are lots of reasons. This is all about obstructive sleep apnea. It also comes. We'll solve all the 2023-2024